Good afternoon, everybody. It's good to see everybody here on this rainy afternoon. I think we were all waiting for this rain. So let's start with today's session of combined clinical rounds. And on behalf of Department of Radiation Oncology, I welcome you all. Today's case is going to be a very interesting case of a neck node with unknown primary. Now you might ask that this is not a very uncommon scenario. Yes, these account for about 5% of all head and neck malignancies. But we at AIIMS New Delhi have this advantage of a wide exposure to rare histologies. So we do get our share of surprises, rarely, not commonly though, and get to learn more about such cases. So today's case is one such case, and this case was mainly treated under Professor AIIMS Biswas, along with our residents who would be speaking about it today. Dr. Anindya is a senior resident from our department, and Nikhil is from surgical oncology, and Sharon is from Department of Pathology. So we all understand the treatment comprises of surgery, radiation, with without chemotherapy. However, in rare cases, we need to look at the literature extensively and then establish a treatment. So this patient was treated with adjuvant radiation following neck dissection and has been on follow-up for over 3 years now. From here, I will invite Professor AIIMS Biswas. So over to Dr. Biswas. He will take you through to the introduction.
Good afternoon. Thank you very much, ma'am. So neck swelling is not uncommon, and there is a plethora of reasons behind neck swelling, which could be infective, inflammatory, vascular, congenital, or neoplastic, which again can be benign or malignant. So the malignant neoplastic lesions which we commonly encounter in our day-to-day practice are carcinoma and lymphoma, and infrequently sarcoma and melanoma. Now focusing on carcinomas of the head and neck, we usually see squams, that is squamous cell carcinoma arising from the head and neck mucosa. Also, carcinomas can arise from the thyroid gland, the salivary gland, the skin, and sometimes we encounter metastatic carcinoma without an identifiable primary. It could be either of squamous, adeno, or neuroendocrine differentiation. So as Madam was alluding to, carcinoma of unknown primary, these are a heterogeneous group of tumors with histological diagnosis of malignancy. They usually present as metastatic disease. However, the primary site of origin remains elusive even after a systematic search for the same. It constitutes roughly 1 to 2% of all malignancies. And particularly in the head and neck, it constitutes 5% of all the diagnosed malignancies. So the common sites of occult primary, which might unfold subsequently down the line after primary treatment, are usually the tonsillar fossa, the base of tongue, the nasopharynx, the posterior pharyngeal wall, and the pyriform sinus. So just one slide on the management principles of neck secondaries with unknown primary in the head and neck. They may be either N1 or more advanced N2, N3 disease. The pathways are predominantly two. So one is the surgical pathway, which usually comprises neck dissection. And this is followed by pathology-directed post-operative radiation therapy with or without chemotherapy, which is usually cisplatin. These patients may also be taken up in the alternative pathway, which is definitive radiation therapy. And if neck nodes persist 3 months after completion of the same, they may be considered for salvage neck dissection. For more advanced N2, N3 disease, we add cisplatin as a companion to radiation therapy. And again, the same principle during follow-up, if neck nodes persist, they may be considered for salvage neck dissection. When the disease is much more advanced, ominous, bulky, we may consider carefully induction chemotherapy, which is usually either TP or TPF regimen, followed by assessment for a neck dissection or definitive radiation therapy. So with this, I would like to invite Dr. Anindya to present the illustrative case. Thank you.
Thank you, sir. Good afternoon, respected faculty members and my colleagues. So I'll take you through the case history of the patient. So we have a 67-year-old male patient presenting us from Nepal who has been diagnosed with hypothyroidism and hypertension about 5 years back and has been on regular medications for the same. He has a history of biri smoking for nearly 10 years and has stopped 25 years back and no family history of malignancy. Who presents with chief complaint of a neck swelling on the left side for last 5 months, which has been painless, gradual in onset, and progressively increasing in size. On clinical examination, his ECOG performance score is of 1, and local examination, there was no evidence of a mucosal lesion on oral cavity examination. However, there was a left-sided palpal lymphadenopathy, roughly epicentered at the level 2 of cervical lymph nodes, 3 into 3 centimeter dimensions, mobile, hard in consistency, and non-tender. There were no other positive findings on systemic examination. The patient underwent a whole body PET CT scan baseline, and here we can see a heterogeneously enhancing necrotic soft tissue lesion, roughly based at the left side cervical level 1B and 2 lymph nodes, roughly of size 4 into 3.6 into 4 centimeter. And the mass is closely abutting the left submandibular gland anteriorly and the sternocleidomastoid muscle laterally with loss of fat planes and a bulk resulting in a collapse of the left-sided internal jugular vein. An FNEC was taken from the left-sided level 2 lymph node, which came out to a monastic carcinoma. ICs run for TTF1 and PEC-8 were both negative. The patient then underwent UGI endoscopy, a nasopharyngoscopy, laryngoscopy, and additionally a colonoscopy and a bronchoscopy. No mucosal lesion were identified in either of them. Hence, we provisionally diagnosed the case to be a patient of monastic cervical nodal malignancy with unknown primary, clinically T0N3B M0 according to 8 AGC classification, giving us a composite staging of 4B. For the surgical management of patient, I'd like to call on the stage Dr. Nikhil from Surgical Oncology team.
Good afternoon, everyone. Thank you so much for giving me the opportunity to present the surgical part in this CCR. I would like to briefly talk about the surgical part in this. So the patient underwent left-sided modified neck dissection, type 3, where we saved both IJV, sternocleidomastoid, and spinal accessory nerve. So we did examination and anesthesia of the oral cavity along with bilateral tonsil. We couldn't find any occult primary as such. And intra-op findings were we found out around 5 cross 6 centimeter solid cystic mass in left neck in 1B, 2A, 3, and 5, which was abutting sternocleidomastoid and IJV. Left submandibular gland was found out to be normal. So we gave apron incision, subplatysmal flaps were raised, and mass was excised in toto of IJV and SCM. So type 3 MND was done, clearing from level 1 to 5, where we preserved the 3 structures that I mentioned before, as in type 3, and including the marginal mandibular nerves also. So closure was done along with the cavity drain, and surgical specimen was labeled and we sent for histopathological analysis. I would like to give back to Dr. Anindya to talk about further part. Sorry, pathology.
Good afternoon, everyone. The histopathological specimen that was received for this case was many lymph nodes, out of which in the level 2 lymph nodes that we had received, there was a single nodal mass which was 4.5 centimeter in its maximum dimension. If we see the microscopic examination, there was complete effacement with neoplastic cells in epithelioid or more like ovoid to spindled morphology, which was syncytial in appearance, and occasional mitosis of less than 1 per 10 high power field. So this is the picture of the lymph node section that we had received, which shows this was the residual lymph node in the periphery, and whole of the lymph node was effaced with tumor cells. And these neoplastic cells were somewhat spindled to ovoid in morphology, and they were arranged in sheets with vague whirling pattern at places. If we go on still higher power, the nuclei are elongated with vesicular chromatin, delicate convoluted nuclear membrane, and every cell would have a small but a distinct nucleoli in this power. So the morphological differential diagnosis was of a metastatic carcinoma first and foremost because of the morphology, and we would expect a positive keratin marker. A metastatic melanoma because of the cytology of epithelioid to spindle cells with minimal nuclear atypia, and it should have been positive for S100 and Milan A. And the most important differential, considering the age of the patient and the presentation of carcinoma of unknown primary, the most important differential was nasopharyngeal carcinoma, non-keratinizing, undifferentiated subtype, and for this, EBV, LMP, and keratin should have been positive. And apart from this, usually sarcomas are not in a differential diagnosis in cases of unknown primary, in cases of lymph node. Only 3 or 4 sarcomas are known to metastasize to lymph nodes. And other than that, follicular dendritic cell sarcoma, just considering the morphology, and one was interdigitating cell sarcoma. So on immunohistochemistry, CK pan-cytokeratin was diffusely negative with positive internal controls. And all the carcinomas, whether it is a nasopharyngeal carcinoma or a squamous cell carcinoma, was by far ruled out with this. S100 was negative, again with positive internal control, which rules out an interdigitating dendritic cell sarcoma and a melanoma. The CD3 and 20 stain, 20 was diffusely negative, and 3 highlights the interspersed background small lymphocytes, and Ki67 was very low, around 3% in the highest proliferating area. Like in this case, we can see some 3 nuclei highlighting on Ki67 stain. While on the contrary, CD21 and CD23, both which are dendritic cell markers, were diffusely positive. So if we see at the immunohistochemistry panel, pan-cytokeratin was negative with P40, which ruled out a squamous cell carcinoma, Milan A and S100, which ruled out a malignant melanoma. MPO, any tumor of granulocytic origin, was ruled out. CD3 is T lymphocytic origin. It highlighted the background small lymphocytes. CD20 was negative. 163 was negative. So any possibility of any monocyte macrophage origin derived tumors were ruled out. And EBV-LMP rules out our other most important differential of nasopharyngeal carcinoma. So with this, we rendered a final diagnosis of follicular dendritic cell sarcoma. Rest of the dissected lymph nodes was negative, and plus on sections, we did not have any soft tissue extension. It was completely an intranodal sarcoma. So the prognostic histopathological parameters, as of now, there is no formal WHO grading system prescribed for this. Earlier in 1996, Perez Orondes et al., they flagged the tumors as biologically aggressive if any 2 of these 4 parameters were seen. Tumor size of more than 6 centimeter, a high mitotic count, significant pleomorphism, or coagulative tumor necrosis, all of which was absent in our case. Our tumor size was only 4.5 centimeter. Mitotic count was not there. Nuclear pleomorphism was absent, and there was no tumor necrosis. But recently, WHO also said that a simple stratification based on tumor size and histology was developed to predict the risk of recurrence. And this was written in WHO. And this is based only on the size and the histology. In this case, they did not characterize based on the necrosis or mitosis. So this was only for the risk of recurrence. So our case was low risk tumor according to WHO system also.
I'd like to thank Dr. Nikhil and Dr. Shirin for walking us through the nuances of surgery and pathology. So the final clinical impression is a 6-7-year-old male patient, known hypertensive and diagnosed hypothyroidism, with history of beer smoking for 10 years, stopped 25 years back, who has been diagnosed with a follicular dendritic cell sarcoma of left cervical level 2 lymph node, status post left-sided modified neck dissection type 3. He was reviewed in our radiation oncology OPD and was planned for adjuvant conformal radiation therapy to a dose of 60 gray in 30 fraction, 2 gray per fraction, delivered 5 fractions per week. The total treatment duration coming up to 6 weeks. To the epicentral neck using 6 MV X-ray energy. The patient was also reviewed by the medical oncology team at IRCH, and in view of locally confined disease, there was no role for adjuvant chemotherapy. For the radiation therapy plan, the patient was placed in supine position with head first, arms by the side, and immobilized using a 4-clamp thermoplastic cast. A contrast-enhanced planning CT scan was taken immediately after injection of radiopaque iodinated contrast from vertex to carina, and the same was imported to Monaco treatment planning system and fused with a preoperative PET CT scan. Coming to target volume delineation, so the structure that we created is a preoperative gross tumor volume, which accounted information both anatomical from the CT as well as metabolic information from the PET, taking account all the tumor tissue that had a SUV of 40% or more of the SUV max. Together, they constituted a preoperative gross tumor volume that was delineated on the pre-op CT. This was then fused onto our planning CT and was adapted in view of the post-op status. Then we go on to create a clinical target volume. This is to incorporate all the microscopic disease that might be left at the post-op bed as well as around it. So for this case, we had taken up the preoperative adaptive GTV, given it an anatomical constraint expansion of 1.5 cm craniocaudally and 1 cm in all other rest of directions. Electively, we took on the left-sided cervical lymph node regions, level 1B, 2, and 3. To account for the errors that come in daily setup as well as patient positioning, we create a planning target volume that is generated by giving a 3 mm isotopic expansion to CTV and was trimmed from the skin surface at 3 mm. We created the other relevant organs at risk that are in the vicinity of our treatment planning, targets, like the oral cavity, the bilateral masseters, the salivary glands, bilateral parotids, the spinal cord. And this is a graphical representation of a dose color wash where we show the area of the body that is receiving a significant dose. In this case, we have been showing the area that is receiving up to 95% of the prescribed dose, that is 57 gray. As you can see, and expected from a conformal RT plan, the dose position has been very well sculpted to the tumor volume that is targeted, while sparing the relevant OARs in the vicinity. And on the extreme right end, we have the dose volume histogram, the volume representing the y-axis and the dose along the x-axis. And very satisfactorily, the curve for the target volumes are pulled towards the extreme right, while the curves for the OARs have been pulled towards the left. And this is the BMI view for the same and on societal impression of the same. The patient completed the planned adjuvant radiation therapy very satisfactorily. There were no treatment gaps of 3 days or higher. There were no grade 2 or higher toxicities during treatment or at the end of it. We are presenting the response assessment at 3 time points, 3 months, 12 months, and 34 months post-treatment. There's a last period follow-up of 22nd of May. On all 3 time points, there was no palpable cervical lymphadenopathy, and the status of complete metabolic response that was achieved at the response assessment PET done 3 months after treatment continued to be sustained at all the subsequent CECT of the face, neck, chest. Coming to toxicity profile, as you can see, the patient had mostly grade 1 toxicities in terms of dermatitis, pharyngitis, xerostomia, and laryngitis that was noted at 3 months and went on to progressively resolve out over follow-up. It's important to remember that the patient was a known hypothyroid, and while the TFT at 3 months of assessment was normal, 12 months post-treatment, there was a rise in TSH levels with subsequent decrease in T3 and T4 levels. The patient was symptomatic for hypothyroidism, and his thyroxine medications had to be up-titrated to 25 microgram a day. And he is continuing on the same, and his last TFT reports were within normal range. So here we have the radiological representation of the radiological images showing a complete response. These are the PET from the baseline, where you can appreciate the FDG avid lesion in the left-sided cervical lymph node level 2. And this is totally cleared out in the subsequent PET and has been maintained in the CECTs of the last scan. Coming to a crisp review of literature, FDCS as a very clear from the name itself, is originating in the follicular dendritic cells present in the primary and secondary lymphoid structures, and has been categorized under the mesenchymal dendritic cell neoplasm family under a stroma-derived neoplasms of the lymphoid tissue in the current WHO classification of hematolymphoid tumors, 5th edition of 2022. Here we have a diagrammatic representation of the lineage-based hierarchical classification structure. And as you can see, up and right, we have the mesenchymal dendritic cell neoplasms, the family to which the FDCS belongs to. So in 1986, March comes the first available literature that had been reviewed of 4 cases of unilateral cervical lymphadenopathy that are analyzed and postulated to be a separate pathological entity based on the morphological, ultrastructural, and immunohistochemical properties to be derived from dendritic reticulum cells, published by Monda, Warneke, and Rosa et al. In the American Journal of Pathology. 14 years down the lane, we have a case report by Chen et al. Reporting the clinical as well as the histological and immunological properties of 17 cases of FDCS. The most commonly used FDC markers being CD21 and 35. There was a clinical association with the hyaline vascular variant of Castleman disease, and liver FDCS had a predilection for EVV infection. 6 parameters were identified to be harbingers of poor prognosis in FDCS, this being the size more than 6 centimeter, an intra-abdominal location, presence of coagulated necrosis, microtic counts of 5 or higher per 10 high power fields, moderate nuclear pleomorphism, and lack of adjuvant therapy. However, on subsequent analysis, only intra-abdominal location and significant nuclear pleomorphism continued to be of statistical significance. And they maintained that complete surgical excision is the mainstay of treatment, while adjuvant treatment may be considered in high-risk cases. Then in 2013 comes the pool analysis of nearly 400 patients of dendritic cell sarcoma, 3/4 of which were constituted by FDCS. The major takeaways from this pool analysis included, again, 4 parameters: age less than equal to 40 years, absence of lymphoplasmacytic response, and reiteration of the previous parameters of size more than 6 centimeter and a high raised mitotic count to be associated with poor prognosis. Multivariate analysis reveals only lymphoplasmacytic infiltration and tumor size to be statistically significant in this regard. And they maintain that early stage disease should be treated with surgery as a mainstay, while addition of adjuvant radiation therapy had no OS benefit, evident from the p-value of 0.47. While locally advanced disease, diverse treatment modalities were applied. So here we have the Kaplan-Meier curves for stratifying the observed responses based on the staging and the treatment modality received by the patient. As very clear, the curve for no surgery dips down, suggesting that non-surgical management might lead to a poor outcomes in the patient, while the curves for surgery alone and surgery plus RT continue to be very closely paced. Again, 3 months later, we have another report coming in of a serum analysis reviewing interdigitating and follicular dendritic cell sarcomas of 74 cases. Again, a bulk being formed by FDCS, 54 cases, over a median follow-up 28 months. The OS was better for FDCS cases versus the IDCS. And for FDCS, stage seems not to be a significant factor determining the OS. And when it comes to treatment modalities, again, 12 of these surgery patients that are localized FDCS went on to receive adjuvant radiation. However, there was no statistically significant benefit of the same. And again, we have the Kaplan-Meier curves for the same. As you can see, there might be a spacing of the curves, but however, they did not translate into a statistical significance. Important to note here that the review articles discussed till now included FDCS of the entire body. In April of 2015, we have this literature coming in from the Hematology Journal reviewing the clinical and pathological features of head and neck FDCS, where 137 cases were reviewed, details have been available on most of the patients, and 106 patients had complete follow-up. The 5-year OS for nodal FDCS was 70%, and for external was roughly 85%. There being no statistical significance between the two. And coming to treatment modalities, 46% patients received surgery alone, while 30% patients went on to receive surgery plus post-op radiation. The dose of positive radiation had a wide range of 50.4 to 70 gray, and only a few 0.8% went on to receive radiation therapy alone. On multivariate analysis, there was no statistical correlation between the treatment molecules received or the oncological outcomes. The article we will discuss in detail and dissect through would be the article by Peng et al. That featured in Head and Neck Journal in April of 2015, which was a pool analysis of 97 cases of head and neck FDCS. So, of the 97 cases of head and neck FDCS, we have 39 cases of cervical nodal FDCS. When it comes to natural history, it has been clear from the Kaplan-Meier curves that diseases that originated in oropharynx and had a tumor dimension of 4 cm or less fared better than the other cohort. When it comes to the natural history, based on the location of the primary, cervical lymph nodes happen to be the second most common, having local recurrence rates of 42%, second only to parotid. And when it comes to treatment management review, 57% patients were treated with surgery alone, while 23% patients went on to receive adjuvant radiation as well. The mean dose of which was 53.45, median dose of 56.25 in the 13 patients that had their details reported. Significant here is to notice that the local recurrence rates with the addition of radiation dropped by 2/3 from 45% to 15%. The p-value being very significant of 0.019. This translating into a not statistically significant, but very definite numerical advantage of OS benefit from 14% to 6%. So this is a reiteration of the pertinent conclusions from this analysis of tumor size being more than 4 cm non-oropharyngeal primaries having a poor DFS, local recurrence pattern being highest for parotid followed by cervical lesions, and local recurrence rates with surgery were reduced by addition of adjuvant radiation therapy. To complete the literature review, we have added an analysis from Kidwai Memorial Institute of Oncology from Bengaluru, reporting 10 cases of head and neck FDCS, 8 of which were tonsil. All cases were underwent surgical excision, while 6 patients went on to receive adjuvant radiation. It's important to know that adjuvant radiation dose is more along the lines of lymphoma, 30 green, 15 fraction. And unfortunately, the recurrence rates were as high as 70%. Only 1 high-grade tumors and 2 of the low-grade tumors remain recurrence-free. The mean and median recurrence-free survival being roughly 40 and 44 months respectively. Important note here is that mean RFS for the high-grade tumors was 44.5 months, whereas contrary to expectations, low-grade tumors, the mean RFS was lower to 37.6 months. The authors derive a very interesting conclusion of this, that perhaps even adjuvant radiation dose as low as 30 gray 50 fraction might not be tumoricidal enough to prevent recurrence rates. However, this did still went on to translate into some local recurrence control, because of these 2 patients of low-grade tumors that were free of recurrence, considered 3 of the patients who went on to receive adjuvant RT. For the conclusion, I'd like to request Professor Ahit sir to.
So, in conclusion, head and neck follicular dendritic cell sarcoma is an exquisite rarity, and it requires strong clinical suspicion, careful history, physical examination, and a very comprehensive and systematic histopathological examination with focus on ancillary tools like immunohistochemistry. The cytogenetics per se is kind of diverse and non-specific. Surgical resection continues to be the mainstay of treatment for such patients. The role of adjuvant therapy needs to be carefully explored. However, adjuvant radiotherapy should be strongly considered in high-risk cases to optimize loco-regional control, as shown in the illustrative case. So now the forum is open to questions and any constructive comments from the audience. And I'd like to thank all the speakers and the presenters for their excellent presentation. I think the tumor was involving level 1B and 2. So we anyway had to irradiate level, to give a safety margin to the tumor, we have to irradiate level 1B, 2. And we also took into account 1 level below, that is level 3 as well. We did not include level 5A and 5B, just 1B, 2, and 3. Yeah, they were like very focused radiation therapy to the left neck, only involving these 3 levels. And this illustrative patient had tumor size more than 4 centimeter. And I think on table, it was more than 5 centimeter as well. And the site of origin was from the cervical node. It was not extranodal. And he has shown that the prognosis is much worse in nodal FDCS of the head and neck. Now, regarding the mitosis, we have been after the pathologist for a very long time. Please tell us the mitotic count. And we came to know the mitotic count today morning itself. And now they're saying it's low risk. But if you take into account the other factors, it is not looking like a low risk. There is high risk of local regional recurrence, as you have shown that the local regional recurrence is in excess of 40% in FDCS of the cervical node, which might be significantly brought down by the addition of radiotherapy. Like this patient is disease-free after 3 years of follow-up. Any other question, please? Quick question. Okay. So thank you again. So that's what I was kind of discussing in towards the fag end. The tumor size was more than 4 centimeter. If you see the Pang paper from John Hopkins, so the size cutoff was 4 centimeter. And it was originating from the cervical node, which is a relatively high risk location in the head and neck, compared to the non-extranodal locations like the Waldes ring. The mitotic count we came to know today morning, a few hours before the presentation. So I kind of like to request the pathology colleagues to furnish this information well in advance so that we can act upon the same.
Largest cohort that was reported was not organ specific. It was not of head and neck. It was of FDCS of the entire body. So the best evidence we found was from a Chang's paper. So that's what we went by.